All right, welcome to the November 16th, 2022 Standard of Care Ad Hoc Committee meeting of the California State Board of Pharmacy. My name is Song Oh, chairperson of the committee. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. This meeting is being conducted consistent with the provisions of Government Code Section 11133. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting must join the WebEx meeting. Information and instructions are posted on our website. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allot 3 minutes to each individual providing comments.
I'm
Similar
sorry.
to, oh, go
This
ahead,
is the
please.
moderator. I'm so sorry, but the webcaster needs to restart his equipment, so we need to pause while he does that.
Okay, today's just a day full of WebEx challenges.
Yes, it is. So sorry. We'll
No
give him.
worries.
Yes. Thank you. All right, this is the moderator, and I'm just doing an audio check for the webcaster. All right, this is the moderator. Webcaster says we're back up.
Perfect. Similar to our October meeting, during certain portions of the meeting today, when indicated, we will allow individuals to comment more than once on a specific question under consideration. During this time, the committee respectfully requests that individuals seeking to provide additional comment reframe restating their previous comments. This approach is necessary to facilitate the meeting and ensure the committee has the opportunity to complete its necessary business. I would like to ask staff moderating the meeting to provide general instructions to members of the public participating via WebEx. Moderator? Oh, hi, Indira. We see you. Welcome.
Hi, this is the moderator, and before we get started, I would like to remind committee members and senior staff who are not speaking to mute their microphones. If I detect background noise during the meeting as a result of unmuted microphones, I will interject with a brief friendly reminder or simply mute the microphones. To facilitate public comment, we will be utilizing the WebEx question and answers feature, also referred to as the Q&A panel. When the committee reaches a point in the agenda at which public comment is appropriate, public comment will be requested. Please note that the Q&A feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. Once given permission to unmute, the member of the public may unmute themselves and verbally state their comment. The Q&A feature is not to be used for typing out questions or for committee members to communicate with one another. And with that, I return the meeting back to you, Mr. Board President.
Thank you, Tricia. I would like to take a roll call to establish a quorum. Members, as I call your name, please remember to open your line before speaking. Maria?
Licensee member present.
Hi, Maria. Renee?
Licensee member present.
Hi, Renee.
Hi.
Indira?
Public member present.
Hi, Indira. Jesse?
Licensee member present.
Thank you, Jesse. And
I'm-
Nicole is.
I'm
Oh.
so sorry. The webcaster is saying that he needs to restart again, so we need to pause. He's
Oh, geez.
Oh,
Would
the
it-
webcaster. I'm so sorry.
Oh, that's okay. It happens.
Yes.
Would it
So,
be easier if we just take a little 5-minute break? I mean, we just started.
I think that
but-
would be a good yes, because
Okay,
he
so we don't just stare at
yes.
the computer screen awkwardly.
exactly.
So
Perfect.
We'll just take a 5-minute break. We'll come back at 2:10. Hopefully it'll be up by then. If we could just make sure
Yes.
that it'll be all good to go by then. Thank you. Thank you, Tricia.
Thank you. Hi, this is a moderator doing a sound check for the webcaster. All right, this is the moderator giving a second sound check for the webcaster.
Hi, everyone. It's back. It's 2:10. Tricia, how are we doing?
The webcaster is now calling his supervisor. He thinks he might have bad equipment. So
Ooh,
Yes.
okay.
I know.
So not ready.
Oh, he says that you can proceed.
Oh, okay.
Well,
All right.
oh, yeah. Well, he says we might proceed. So he is on this meeting. So,
So should we proceed?
let me double check. I'm sorry.
Okay. That's okay.
All right, this is the moderator, and the webcaster is saying to proceed without him. He'll just have to use a recording of the meeting.
Okay. Eileen, is that okay? Are we allowed to proceed? Just want to confirm.
I'm sorry, President. Oh, I just got back, so I missed on whatever you were asking.
Oh, so the webcast, DCA webcast is not working. Can we proceed?
Yes, because what we say in the agenda is that we'll go forward as long as the WebEx is moving, that we would continue if the webcast is unavailable.
Okay, all right. As long as there's no legal concerns, we will proceed. Is everyone back? I know Jesse's camera's on. Maria, India, Renee, are you guys? Oh, there you are. All right, we'll proceed. We'll take a roll call one more time. Go.
President, oh, hi, it's Eileen. I think we should take a roll call on the record, though, because we had a break just to make sure that there's been no technical disruption
Yeah,
with the board.
yes, Eileen. Thank you. I was about to, yes. Maria?
Present.
Thank you, Maria. Renee?
Licensee member present.
Thank you, Renee. India? India may not be back. Jesse?
Licensee member present.
Thank you, Jesse. Okay, so with that, a quorum has been established. Members, and I am here for the record. A quorum has been established, members. As we begin, I'd like to thank all of you for your time and, oh, there's Indira. Indira, can you just verbally confirm you're here?
Public member present.
Thank you, Indira. Thank all of you for your time and commitment to evaluation of this issue. This issue may appear on its face to be simple, however, it is quite complex. I ask everyone participating today to be respectful of the work before the committee today. We encourage participation by members of the public throughout our meeting at appropriate times. The committee respectfully requests that when comments are provided, they are done so in a professional manner, consistent with how the committee conducts its business. I will now open the meeting for public comments for items not on the agenda. I'd like to remind members of the public that you are not required to identify yourself, but may do so. I would also like to remind everyone that the committee cannot take action on these items except to decide whether to place an item on a future agenda. Members, following public comments for this agenda item, I will ask members to comment on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the committee and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Moderator, we are ready for public comment from individuals participating in WebEx.
Thank you, Mr. Board President. I've opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists. Or if you've called into the meeting, you may press *3 to raise your hand. We will give you a moment. All right, I see that we have Christopher Atkins with a raised hand. And just please keep in mind, we have a 3-minute time limit. And Christopher, you should be able to unmute yourself.
Adkins. I was just going to make a comment, not to any particular part of any of the questions we discussed previously or any of the ones that will be discussed here, because I didn't know exactly where it fit. But in discussions since the part 1 of this discussion, it came to my attention that maybe part of standard of care would include things like naloxone administration, because I know a couple of pharmacists, myself included, have come into a scenario in the community where administration of naloxone might have been needed. And I think that should be something that's treated as a standard of care model, because in my scenario specifically, someone was having an overdose in the bathroom of the store that I was at. So in order to go help them, I had to abandon the pharmacy, which legally I'm not supposed to do. I didn't close it because there was an emergency, which I'm legally not supposed to do. And the person was having an overdose, which I confirmed by paraphernalia that was around, and the person that was with them also told me exactly what had happened. And so the obvious thing to do at that point would have been to give them naloxone if it was necessary. Fortunately, I determined that it probably wasn't at the time. They were breathing, there was eye movement and everything, but I did have the technician get a box ready in case things took a turn for the worse. So at that point, was I stealing a box of naloxone? I didn't pay for it. There was no prescription. If I had taken all those legal things into account above the safety of the patient, then they could have possibly suffered potentially death, potentially any other problems that could have happened had I not administered the naloxone, if I had been following the law specifically to the T. So I think that is a scenario that maybe we need to think about specifically in an emergency situation. And that was just how I reacted. I heard that another pharmacist that happened to a patient was actually outside of the store, and she was asking if she should administer care to the patient in that scenario. And she was told by her district leader that since they weren't in the store, she should not have administered care. And in that case, I mean, I think our ethical obligation kind of overrides that. I personally probably would have gone to administer care, left the farm, done the exact same thing I did in this scenario. And I think that we probably need the legal protection in that case to treat that as standard of care rather than specifically by the books in the law, because some people might be going over in their head, oh, can I do this? Do I need to ask permission? What's the legal ramifications, rather than just putting the patient first and potentially saving a life. So I didn't know where that thought fell exactly in the discussion. I just thought that it was something that kind of needed mentioning, and maybe we can talk about it in a point here, maybe somewhere in there, just to put it out there. And also, as a side note, I did try to contact Singapore, but no one's gotten back to me yet. So just want to mention that. Thank you.
All right, and I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you. Thank you so much for the comments, Dr. Atkins. Your comments are appreciated. Members, do you have any comments you would like to, any thoughts?
Hi, Sung. This is Jessie. I'm not sure if this is necessarily like under a standard of care thing or if this should be at another board meeting, but I think this could be something that we bring up as a future agenda item somewhere, just given the amount of overdoses that we're seeing across California. So I'm open to discussion in terms of like which meeting would be the most appropriate for a discussion like this.
Absolutely. This is definitely in something that I have it in mind. This exact scenario, actually, something that I was curious and was concerned about myself as well. So I would absolutely try to bring it up in some way possible for us to discuss in the future. But I think what we're discussing here in standard of care could potentially impact it as well. But we'll definitely bring this up.
Great, thank you.
Any other thoughts? Okay. All right, so we're ready to discuss, starting back to next agenda item 3, continuation of discussion and consideration of policy questions related to standard of care enforcement model in a practice pharmacy. As I did at our last meeting, I would like to remind everyone present of the language provided in Business and Professions Code section 4301.3, which states on or before July 1st of 2023, the board shall convene a work group of interested stakeholders to discuss whether moving to a standard of care enforcement model would be feasible and appropriate for the regulation of pharmacy, and make recommendations to the legislature about the outcome of these discussions through the report submitted pursuant to section 9795 of the government code. Thank you again for your patience while I read that section of the law. I think it is important for us to remember what the legislature is asking of the board. As we have discussed on several occasions, the board already uses a hybrid standard of care enforcement model, as I did during last meeting, as it is required for us to have somewhat clear consensus and notate if dissent is voiced for the purposes of the report. I'll be calling each member for each question. Some questions could just be simple as I agree, but I wanted to make sure we capture your thoughts as a whole committee. In many cases, I take your silence as you generally agreeing along, but for this discussion, I'd like each of your clear thoughts on each question. Lastly, we'll be opening this topic for public comments for 3 minutes, as presented in the meeting earlier comments. Before we resume our discussion, I also want to provide a brief summary of what we have discussed so far. There appears to be some consensus that the board's current enforcement model, which is a hybrid, is appropriate for facilities licensed by the board. As part of our discussion, we noted that unlike pharmacists, facilities do not have extensive education and experience, nor do they exercise professional judgment. There appears to also be consensus that the board's current enforcement model is appropriate in the regulation of non-pharmacist licensed personnel, such as pharmacy technicians, designated representatives, and possibly interns. Members noted that there may be an opportunity to expand the scope of practice for pharmacy technicians. However, pharmacy technicians operate under the direct supervision and control of a pharmacist. Further, committee members noted that the technicians should not have discretion at this point. The committee then transitioned its discussion to evaluation of the questions related to pharmacists and PICs. As part of the comments, it was noted that the board may need to draw a distinction between a pharmacist and a PIC, noting that a PIC is responsible for compliance with the law. Members also noted the different types of practice settings and functions that a pharmacist may perform and the need to perform clinical judgment. There appeared to be some consensus that there is opportunity to use a more robust standard of care enforcement model for pharmacists. Public comment also appeared to agree that there is an opportunity for more robust use of a standard of care enforcement model for pharmacists. One large challenge identified during our discussion is how a PIC can be autonomous and control the operation of a pharmacy when corporate practices exist that undermine PICs. Following discussion and questions related to the use of the standard of care enforcement model, the committee transitioned to a larger question regarding opportunities to remove some of the prescriptive provisions that currently exist with some of the current authorized scope of practice. There was again consensus that opportunities do exist and noted there are many opportunities for regulations to be less restrictive. Members also noted some challenges with such a transition, including pharmacists would be empowered to provide clinical services autonomously. Members indicated the need for some consistency and to ensure pharmacists are appropriately educated and trained to provide the services. Members also considered if current CE requirements related to specific authorities would still be necessary. Public comment also appeared to be in support, with some commenters noting the number of specialties available for pharmacists. Comments indicated that a standard of care enables pharmacists to exercise professional judgment. Members concluded also that changes to regulation should not be limited to specific practice settings. The committee also appeared to reach consensus that a transition to a standard of care could result in expanded access to care and improved patient outcomes. Members noted that some conditions may be necessary and cautioned that as the board moves forward, it is necessary to make sure that the unintended consequences is not a lowering of the standard of care. Public comment agreed with members. Members also considered if minimum requirements on training or education is necessary or requirements to ensure baseline competencies are met. Members noted some challenges. Some members noted that need for some minimum training, while other members cautioned about being too specific. As we continue our discussion today, I would like to begin with more discussion about training. Specifically, does the committee believe that setting minimum requirements on training or education or requirements to ensure baseline competencies across the state is preferable, or to allow for deviations based on geography, size of practice, or other variables? I believe we can look to the advanced practice as a possible model. As we learned from our presentation from Dr. Chan, extensive training is required to perform these advanced duties. I do not believe geographic differences would be appropriate, or we could have differing levels of minimum care across the state of California. We need to advance patient care while ensuring healthcare equity. So members, with that, so we're at policy question 5B. Does the committee believe that setting minimum requirements on training or education or requirements to ensure baseline competencies across the state is preferable, or to allow for deviations based on geography, size of practice, or any other variables? I will start with Maria.
I'm still trying to process that because I was listening to what you said. So you jumped right into the question. I know it's been on the screen for a little bit. Setting minimum standards on training and education. I believe that there should be minimum standards, that it's not necessarily by geography. We kind of talked about that with other questions. Size of practice, I think, is kind of an interesting discussion to have. I'd be interested to see what other people say. There's the shared practice, where we have teams in place. And then you have the independent practitioner, which, we are leaning more and more towards. I think that I'd be interested to see what other people have to say about that. But I do believe that, we are required to have some sort of minimum requirements, and that may be the minimum requirements of licensure and not a secondary level. So that's kind of where I'm leaning.
Thank you, Maria. And we'll go to Renee next.
Hello. Yeah, I kind of probably echo a little bit about what Maria said as well. I would agree that some minimum requirements should be established to provide a standard of care practice. The minimum requirements would need to be determined, however, whatever that might be in the whatever area, but they would also need to demonstrate that they've met these requirements and it's somehow verified. So again, nebulous, but exactly how that might be. But I think since quality patient care is required, any kind of lack of qualification, possibly based on, like this other, based on geography, size of practice, et cetera, still wouldn't be in the interest of patient safety.
Thank you, Renee. India?
Picking up on that term, yes, I think to ensure patient safety, there has to be a baseline level of competence that is applied across the state. That it would be bizarre that walking from one county line to another county line, one city to another city, could result in a lower level of competence, and that patients, depending on where they live, where they can live, would receive a different baseline level of competence. So I firmly believe that there has to be a standard minimum baseline level of competence. The details of that and how and in what capacity, we need to discuss further, but yeah.
Thank you, Indira. Jesse?
Yeah, I'm struggling to envision what the minimum training or education would look like. You know, we already have the CPJE, which is California's own determination of competency for practice. So I guess the question, and I mean, this is, I guess, up for discussion with everyone, is, does this mean that we would require some sort of exam? Is it going to be like a CE training? I don't think it should necessarily be different based on geography or size of practice, but then if we're looking at competency, the only thing I think of, if we're looking at standard of care, the training may look different depending on what the practice is to determine the baseline competency. So then that gets into the question of how many different types of training we would actually have. And it's hard for me to picture what that would actually look like. I don't know if anyone else has any feedback on that.
That's exactly, you're right, Jesse. That's where I think we are all kind of thinking as well. And so I think we do agree that there must be some sort of minimum requirement. I think it's that question, Indira, which is, what is that if we go for standard of care model? Is current requirements that we have enough? Should we actually not be so prescriptive about CE requirements on certain topics? Can we rely on the practices to actually provide trainings, etc.? All that is, kind of where we need to figure it out. Any other thoughts before we move on to public comment? Okay, seeing none. Tricia, if you could please go to public comment. Thank you.
Thank you, Mr. Board President. I'm opening up the Q&A panel, and if any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists. Or if you've called into the meeting, you may press *3 to raise your hand. We are displaying instructions and we'll give you a moment. All right, we have a request for comment from Daniel Robinson. And Daniel, you should be able to unmute yourself.
Comment. The minimum standards have already been set. We have a accreditation council on pharmacy education that sets standards for graduating pharmacists. We have licensing requirements that all licensees in the state of California pass the NABPLEX and the CPJE. Those are your standards. If you look at our business professions code, licensed pharmacists are healthcare providers in the state of California. So we're already qualified to provide healthcare. What we're trying to do is create a regulatory environment that supports our ability to provide quality healthcare services. I just think it'd be a huge mistake to try for the board to say, try to distinguish or differentiate, because all licensed pharmacists they're licensed and prepared, they're practice ready, they're team ready, and look at the pharmacist population in California. There's a lot of people in community pharmacy practice, but right out of educational programs, they're also going into institutional practice. Many of them choose residency programs and go on to other areas of specialization. But remember, in medicine, all of the specialties they have, 40 specialties, 87 subspecialties, there's nothing in their laws that say that they have to have different level of training for all of those things. That's really based on the standard of care that's required to deliver if you're a surgeon, or if you're focused in oncology, or if you have a specialty area of practice. So pharmacists need to would not do anything they're not qualified to do. And they're all qualified to provide direct patient care. There's only 3 states in the United States where licensed pharmacists right out of school are not permitted to participate in collaborative practice agreements. So everybody else across the United States is doing this. And you've got National Association of Boards of Pharmacy, you have American Association of Colleges of Pharmacy, APHA, ASHP, all support a move toward a standard of care regulatory model. Thank you.
All right, the next request for comment is from Kevin Kamato. And Kevin, you should be able to unmute yourself.
This is Kevin Komodo, pharmacist representing myself right now. I want to speak in support of what Dean Robinson stated as well. I'm really glad that the committee is not wanting to divide this up, especially by county, and I think we can see the challenges that would pose and the potential issues that would create for patient care. I agree with what Dean Robinson was saying too, in that Mike, to add on to his comments, one of my concerns is that we would now be creating like additional levels. Not to say that there's not or that we shouldn't be trying to attain higher levels of education. I think we need to, but implementing a new level just for standard of care is going to bifurcate pharmacy as a profession, when I think we do need to state that, as Dean Robinson was saying, we already have a methodology for being able to state that pharmacists are practice ready. But now it's just making sure that that standard also speaks to standard of care, which would become the main method for people being able to provide care, and the standard at which all pharmacists would be held. I think it's extremely important and would simplify the process. So I believe, and I can't remember if it was Jessica that made the statement, if it was Indira that made the comment, but yeah, I agree completely that it would be through the current processes, and just making sure that they test for the standard that we want to set. So thank you.
All right, I don't see any further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you. Thank you for the comments, everyone. Okay, with that, any other member comments before we move on to the next question? Don't see. So question 6. Next slide, please. Members, the next question for our consideration is related to working conditions. Specifically, if we believe under current working conditions, a transition to a less prescriptive scope of practice is possible and appropriate, and if so, under what conditions? I'll start saying with that working conditions is a large problem that we cannot just ignore. I noted in the survey responses that challenges appear to exist also in the hospital environment as well, which was little surprising, but I guess I shouldn't be surprised as well. I question if we're setting pharmacists up to fail if the board removes some of the specified requirements related to performing some functions without putting in sufficient safeguards to ensure appropriate staffing and resources available. At this time, I'm not sure removing some of the prescriptive requirements included in the scope of practice can be done in a safe manner in some environments, particularly in the chain setting. So for example, who would develop policies for providing clinical services and be responsible for ensuring a pharmacy is adequately staffed for pharmacists to perform such services without sacrificing the quality of pharmacy's dispensing of medications while continuing to provide consultation, which is vital to preventing medication errors. Expanding access is necessary, but only if I can be done so in a safe and appropriate manner. I am hopeful, though, from discussion earlier from our Medication and Error Reduction and Workforce Ad Hoc Committee, that we can simultaneously pursue these reforms that will garner more autonomy for PICs to determine appropriate staffing levels and such. So if that were to happen, I feel more encouraged that we could pursue such reforms. I'm sorry, it's a loaded question, throwing a lot of layers there to our members. So just wanted to start there, and I will go with Renee.
Yeah, I think, similar to some of the points you made. Yeah, I mean, I definitely think that that a transition to a more expanded scope of practice is a possibility, certainly based on all the presentations and information that we've had and we've read. But I do agree that the consideration of the current conditions in retail settings, retail chain settings, anyway, would have significant hurdles to overcome to provide all the services, especially in busy pharmacies, recognizing that there's definitely a lot of variabilities within that. However, what we've seen is those pharmacists reporting that they're too busy. So the conditions to provide additional clinical services require that pharmacists have the time required for adequate patient care without the burden of the staffing or competing demands and responsibilities of the pharmacy in order to give the best care to patients.
Thank you, Renee. Indira?
I agree that it is a very loaded question based on everything that we've heard that has been presented to this committee. So, I mean, with a yes or no answer, my feeling is that no, that under the current working conditions, that in and of itself is a very loaded phrase. And I don't have clarity on what that means. And if we're talking about an expanded scope of practice scenario, it's unclear to me whether or not quote unquote current working conditions is now a variable that would be used to set what is, an appropriate scope of practice or standard of care. So that is concerning to me. So I think, again, that phrase is so loaded that I don't see a way of answering yes to that first question.
Thank you, Indira. Jesse?
Thank you. I agree. I don't think it is appropriate given the current working conditions, and I would like to see an improvement in working conditions, particularly at our retail chain pharmacies before any transition were to occur. Some of the concerns I have too, in terms of moving over to a standard of care model. Number one, there needs to be a minimum staffing level. So that's one of the issues that needs to be addressed in working conditions. As mentioned previously, some of our pharmacies are so busy they can't do things. But I also want to point out that some of the lower volumes stores end up being completely understaffed, and you may have a pharmacist working entirely alone. A lot of our pharmacies are required by their employer for chain settings to take appointments for patient care services. So this might be immunizations, it could be testing, etc. And they don't have the autonomy to actually change or access the appointment settings. So that's a big issue that exists under current working conditions. And as it is, according to our workplace survey, the majority of pharmacists don't believe that they have enough time to provide patient care services as it is. So expanding the scope of practice doesn't make sense until we address why it is that pharmacists are feeling that way. And this is getting into a future question, but I do believe it ties into the concept of if we were to transition to a standard of care, who is going to be the one developing that standard? And I'll just start to put out the feelers, but I strongly believe that it needs to be working pharmacists within those settings who are creating the standard. It can't just be people who are supervising or working for corporations. It needs to be pharmacists who are actually working on the ground and on the bench who are making the standard.
Thank you, Jesse. Thank you for your comments. And Maria?
this is very complicated, as everyone has mentioned. And in fact, it's an area that we've tiptoed around for many years, if not decades, about workload and what is appropriate and safe. A lot of times we defer to like HR policies or employment policies and tell the professional that if they feel that that's too much to do, just like any other job, they should go someplace else. That's not always a good answer. It's a short-term kind of solution, but that's not the answer for the problem. We, like I said, tiptoed around it by having new regulations about not having quotas, quotas for number of prescriptions or for number of activities, vaccinations, or whatever that would be. We have ratios for technicians and pharmacists. And so that's kind of tiptoeing around the issue also. I think it really comes down to is how do you create some sort of measurement or metric that I don't think ideally should be regulated. That's kind of scares me and myself too, but metric or measure that would assure that there is a safe environment, that there is adequate personnel to provide the care that's needed. So even looking at how things are now and have been historically, we've never done that. And we've never said that, pharmacy has 100 prescriptions, they have one pharmacist. They have 200 prescriptions, they have 1.5 pharmacists. We've never done those kinds of things. So where would you even start? And can it be done? I know in acute care, they tried to do that for a number of minutes per IV or number of minutes per aminoglycoside protocol or number of minutes per, cart checks that you're doing. And, MBAs come down and tell the departments, okay, you need 14.25 FTEs to do the work that you've documented. That didn't work in acute care. So I don't know how you would do anything like that. So I think that's is the crux of the issue, and how we implement a standard of care process to assure that it is safe, that we're actually not creating problems and having that unintended consequence term that we talk about.
Thank you, Maria. Great points there, everyone. Definitely a tough question to ask. I don't think we have answered today, but we have something definitely to ponder about in the future discussions. So with that, I will open up for public comments and see what we have to get to hear.
Thank you, Mr. Board President. I've opened up the Q&A panel. If any member of the public would like to comment, type comment using the field in the lower right-hand corner of your screen or simply raise your hand. And I see we already have several people raising their hands. So we will start with Christopher Atkins. You should be able to unmute yourself.
Hello, this is Dr. Christopher Adkins again. Could I ask that the slide be brought back up with the actual wording of the question, just so that I can reference back to it? Thank you. Yeah, so this is very complicated. It's kind of a question within a question within a question. So the first thing I want to say is I don't believe, and I think we talked about this in part one, we're not talking about an expanded scope of practice here, but rather switching to a standard of care enforcement model. So I'm not sure if that was what was meant in the question exactly, or if we are actually talking about expanding the scope of practice here. And then the second part I'll address is it possible and is it appropriate? And then separately, if so, under what conditions? Because I feel like those are three separate questions. So under the current working conditions, is it possible to transition? Yes, I do believe it is possible to. I don't think it would be in the best interest of the patients and the pharmacists at this time, partially because of what Jesse said. And developing the standard of care, who is going to be developing that standard of care? Because as we saw from the survey in part one, a lot of the times, especially in community, the pharmacists in the pharmacy actually making the decisions don't have a lot of the decision-making power. So I think we really need to take into consideration who is making those decisions and who is developing the standard of care. And I would agree exactly with what Jesse said, that it needs to be the pharmacists in the pharmacy making those decisions, not just people crunching numbers in the background. It needs to be the people on the front lines that are making that decision. So I think that kind of answers the if so, under what conditions. And those are the only conditions that I would really feel comfortable doing that in the community setting. I can't really speak to the hospital or any other specific setting, but I would say in the community, there needs to be some sort of a provision that puts the power in the hands of the practicing pharmacist and kind of takes it out of the hands of the district leaders that might be responsible for, you know, several counties worth of pharmacies, basically, because each pharmacy is different and each patient is different. And I think the whole point of moving to a standard of care is being able to give individual attention to each patient rather than just creating this overarching bunch of policies that is maybe good for the gander but not necessarily good for the goose. And I think that that's the situation under which this would be appropriate. So hopefully that answered all of the questions within the questions. It is possible, I do believe, but it's going to take some work.
10 seconds.
And I believe it's only appropriate if the pharmacists are the ones making the decisions, the pharmacists in the pharmacy. Thank you.
All right, the next request for comment is from Daniel Kudryshov. And Daniel, you should be able to unmute yourself.
Thank you. Can you hear me okay?
Yes.
Thank you. I very much agree with the former speaker. And I would say, so first of all, to introduce myself, my name is Daniel Kudryshov. I work as a medication safety officer in a hospital setting. I'm speaking on behalf of myself as an individual. And first of all, I fully support transition to a standard of care enforcement model. And in fact, I see it as very well integrating with the existing hybrid enforcement model. And the reason I say that is that in my reading of this, moving to the standard of care enforcement model would not undo any existing specific laws and regulations that pharmacists would be expected to comply with. So the standard of care enforcement, approach would apply in situations that are not directly explicitly governed under existing law. Of course, law can change in the future, but the standard of care enforcement model would not change undo any existing regulations just by itself. So that's just one point about that. And so I don't necessarily see it as an expansion of scope of practice by itself. But to answering the question whether or not it would be, looking back at the question here, is possible and appropriate to transition to a more expanded scope of practice. So I think it's not really about the scope of practice, but it is possible to move towards that model. And speaking from my experience in a hospital setting, I would say that we already adopt the standard of care enforcement model in evaluating pharmacist work from a clinical perspective. And whenever there are issues raised by patients or by staff around the level of care that is provided by the pharmacy department, in investigating what happened, what should have happened, was there patient harm, we do adopt this standard of care mentality in the current environment. I mean, currently, this is what we do. We look at what were the institutional policies. If it's governed by policy, great. I mean, we have our answer. It's black and white, maybe. If not, we look at the standard of care. Well, what should a rational pharmacist have done in those conditions? And if the answer is that the rational pharmacist would have done the same thing that this pharmacist had done under the same circumstances, then that's it. We don't hold the pharmacist accountable. So my point is, I think we actually do this now.
10 seconds.
In a hospital setting, and I would definitely say, yes, it's possible to do it. It's kind of current practice, in my opinion. Thank you for the opportunity to comment.
All right, and the next request for comment is from Daniel Robinson. And Daniel Robinson, you should be able to unmute.
Thank you. I agree with, many of the comments that have just been made. I really think it's important for us to sort of uncouple the two concepts, scope of practice and standard of care. There's nothing in, if we were to apply a standard of care regulatory or enforcement model, it's not changing scope of practice at all. Maria Serpa, maybe a couple of meetings ago described some of her clinical responsibilities in an institutional setting and, the value of those services and the types of decisions she was being asked to make on a regular basis. This is what we're talking about. We're talking about things that as healthcare providers, we need to have the flexibility to make the best decisions for our patients based on the information that we have as we're involved in direct patient care or in collaborative based team practice. And there's no way that a protocol that's written as part of a regulatory guideline or within the Business Professions Code should or could cover all of those eventualities. So we are not asking anybody to do anything that they aren't currently doing or that they're not capable of doing, because standard of care will always ask the question, you need to be qualified to do the things that you're doing, whether it's in a collaborative practice agreement and an institutional setting, providing anticoagulation therapy management. You have to have those qualifications, and part of the evaluation process during standard of care is to evaluate your conduct based on the standard that's set by other practitioners in your field. So thank you.
All right, the next request for comment is from Kevin Komodo. And Kevin, you should be able to unmute yourself.
Thank you very much. Going back to the question, I think that the conversation has shifted a little bit. It's kind of become a question of, does the committee believe that under current working conditions, a transition to standard of care is possible and appropriate? That kind of seems to be the gist of where we're going with the conversation. One of the things that was brought up was the question of, given the current retail pharmacy environment and some of the things that are occurring there, would that be possible? I have some fears from a public safety standpoint if we were to wait on this, because I think it would delay the emergence of different types of clinical services that could be applied throughout the state to be able to improve access to care. Just as an example, within our pharmacies, which are in the Kern County area, we've just started seeing diabetic patients under the DHCS MTM program. And we've had engagement with the patients under collaborative practice with their prescribing physicians. And we had a patient that came in July when we had initiated the program. Within the last 3 months, we were able to already drop her A1C 3 percentage points and working with conjunction with the physician on being able to adjust her diabetes medications. There was a lot of back and forth that had to occur to make those types of things happen. Right now, this occurs because we were able to establish those types of relationships. And granted, I wouldn't want to go in and just start making changes on any diabetes patient. There needs to be some sort of a rapport. There needs to be a standard by which the pharmacists are trained. But the standard of moving to a standard of care model opens up the opportunities for these types of interventions, which I think is huge, especially in rural areas where we're serving, like our biggest pharmacy is in Delano, which has a population of about 15,000, which is not too small, but it's not big either. And there's a lot of issues with access to care. I really would not want to see us delay that. Getting to the question about then, there are still concerns with trying to apply it in the retail chain setting. I think one of the things we can do to solve that is by empowering the pharmacists. Give pharmacists the ability to be able to refuse in certain situations to determine, are they capable of providing that care and not letting a corporation decide that on their behalf. I think that's one way to achieve it, which speaks to the nature of standard of care, but also kind of helps to create some sort of a model that would also allow for the implementation of more standard of care models. So thank you.
All right, and I see no further requests for comment. Shall I close the Q&A panel?
Please, thank you, Tricia. Thank you, everyone, for your comments. Really appreciate your thoughts. Members, with that, any additional comments you want to make or any other discussions you want to have? Don't see anyone raising their hands. So we'll move on to the next question, question number 7. As we continue, if we believe that expanding some of pharmacists' clinical duties by using a standard of care model is appropriate, do we believe it is appropriate to allow business to develop policies and procedures for pharmacists to follow? Or could such a practice impede a pharmacist's ability to exercise professional judgment? That's the first question. I know that it's interesting. We are asking, the Board of Pharmacy is asking if there's too much policy and procedures, or, I understand our law requires a lot of policy and procedures, but remember, we're discussing policies and procedures related to pharmacists' clinical or professional judgment, not policy and procedures related to business functions like inventory reconciliation. So this is, one of the biggest challenges, as I think Jesse already kind of previewed. We learned from Carrie Webb from the Council for the Medical Board, there exists a bar on the corporate practice of medicine. There is not a similar bar in pharmacy. So I believe if we believe pharmacists need to be positioned to work and practice under a standard of care model, I do not believe that in general, a business should be allowed to develop policies and procedures dictating pharmacists' practices or telling how pharmacists should exercise their professional judgments, unless the pharmacist maintains sufficient autonomy and can override the policies when deemed appropriate. Understanding that business develop multiple policies and procedures, many required by our pharmacy laws, but those are policies and procedures that involve pharmacy license, not pharmacist licenses in general, and functions. So I believe when a pharmacist is working under a pure standard of care model, absolute autonomy is necessary. So I'm curious to hear your thoughts on these, members. And so we'll start, I think this is Indira.
As a public member, I go off of everything that we have heard. And it does seem to be that there is tension between pharmacists exercising autonomy and exercising their professional judgment, tension between that and being forced to follow certain policies and procedures set by a business. So it seems like it would not be appropriate based on the information that has been presented to us and the comments that I've been hearing. But I'm definitely curious to hear what other people have to say with more professional experience than me.
Thank you, Indira. Jesse?
I know we heard examples of this in the last discussion, but Sung or any other board members, does anyone remember have a specific example in which a policy or procedure actually conflicts with standard of care or like providing patients care? Because I'm struggling to actually think of a scenario.
Someone has raised their hand. I don't know if Kevin is trying to, I would be, Eileen, if that's allowable, I would like to have him speak, or we could probably. Trisha, I'll just go ahead and let him go ahead and speak.
Oh, can I? So, Jesse, I think maybe some of the examples might be where there's like a hard stop, like in the computer system. So, like you couldn't actually even like provide the medicine, even if you determined that it was appropriate, because there's like a hard stop in the computer system that would like prevent you from actually doing it, or a controlled substance. And like those are the kinds of things that I'm kind of recalling as an example.
Got it. Okay. I don't know how a pharmacist would really be able to bypass a software hard block as it is. I will say generally at the moment, I feel as though a business should be able to develop their own policies and procedures just to create a standard across their stores, and because they do have a facility license. That's on the line as well, but I am open to hear the conversation and see what everyone else thinks, and possibly hear some more specific examples.
Thank you. Maria?
I kind of see this as in two different areas. You know, when it talks about clinical judgments, patient care, I don't think there should be policies and procedures per se. There should be, you know, what the standard of practice is, and whether the standard is different from site to site, that could be appropriate. Where I do see policies and procedures playing a huge role is in continuity and for patients and access. You know, when we're looking at larger practice settings where it's not an independent pharmacist and the pharmacist is not seeing the same patients all the time, there are multiple pharmacists involved. Pharmacists have days off, they have vacation, the store is closed for holidays. I think there needs to be some sort of policies and procedures about continuity of care, access to care, how they start care, how they end care. Those kinds of things I think are really need to have some sort of documentation of as to how that's done. The issue that Jesse kind of referred to and Anne gave an example, that one's a harder one because that one sometimes are not store policies and procedures. They're regarding maybe insurance coverage. So, you know, the store will have maybe have the inability to provide a medication that the pharmacist thinks that the patient should get. That's not really a store or company policy and procedure. That's kind of a contractual issue, I guess you would say, of the pharmacy and of the patient. So I kind of see that as a separate issue that does need to be discussed, because there has to be a way of getting medications that are clinically important to a patient that quote unquote aren't covered. We need to figure that out too. But to round it out, I think there needs to be policies and procedures when it comes to process, but not to the clinical decision.
I'm just going to jump in a little bit and add a little commentary. I think what we're trying to get to the bottom of is if we say the protocols that we have currently for certain pharmacist functions, if we were to just erase them and say, let the standard of care be the answer on how you perform those functions. And then if a company decides, because whatever the reasons, their liability reasons is what I could think about. And if they decide this is how pharmacists must do, now at that point, is that something that we think, you know, because what I personally, you know, don't want it to happen is we remove protocol, and then instead of protocol, just it's policies and procedures, not pharmacists really being autonomous and being fully using their professional. So that's kind of where my thinking is on this issue. So Maria, go ahead. I know you raised your hand, so.
Well, just I guess to take on that kind of question, give you some experience on what happens in acute care where you have 20 or more, sometimes 50 pharmacists that are providing care according to protocols. Everyone has their own little slight adjustment or opinion. And so then the way that we spend a lot of time actually in for doing competencies and ongoing training in acute care to assure that there is complete consistency with the protocol, that the person does not waver and say, well, I don't agree with the protocol, I'm going to do it that way. So if we did not have a protocol, for example, then there is a lot of inconsistent practice that could happen. Is that clinically significant or not? I don't know. I think it would be like I said, you know, my experience is in acute care. It could be if you're dealing with an aminoglycoside in a dialysis patient and somebody believes one thing and the other person believes something else, that could be clinically significant. Or a neonate versus a 110-year-old patient, that's clinically significant. Now you would hope that those people are experts in neonatology and geriatric and aminoglycosides, but you still have difference of opinions. And that's why the professionals get together and they determine what is their standard of care. And the way they do that is they write a protocol. So that's my background on that.
Thank you, Maria. That adds a great thoughts into our discussion for sure. Renee?
Yeah, thanks everybody for all those comments. I don't know that I'm going to add anything different than what's kind of been said, but I do agree that that as a business, there's definitely going to need to be some policies that guide the business that's going to include the pharmacist. But as far as, providing clinical services, there may be some overarching policies, but none of them should hinder a pharmacist's professional judgment or exercise their best clinical practices. So I don't, there may be some kind of Venn diagram here where there's some overlap, and then there's, there's can't be too much overreach into the pharmacist's clinical practice. So and then there are, because there are, as been mentioned before, system and just processes, maybe you want a drug, but it's like not available from their distributor, anyway, so however those barriers might be overcome, but if things were developed in terms of the clinical part, certainly in either by pharmacists or with a lot of oversight and final opinion of some of these things, if whatever would get established. So that is a little complicated, but I do see that there could be some policies for the business, but again, it's going to be defeating to the pharmacists if it's too restrictive and prescriptive.
Thank you, Renee. Before we go to public comment, any other thoughts?
Hi, Sung. Yeah, I have a couple more thoughts after listening to everyone. So I understand, Sung, where you're coming from, where the fear is if we remove regulations and replace everything with a standard of care model, does that leave the standard of care, quote unquote, entirely up to the business? Or, and I mean, I would say the biggest concern, of course, would be for chain retail pharmacies, and thus allow them to completely decide what the standard of care is for all of their pharmacies. But I thought of another example in which a policy and procedure may conflict with clinical care. So if you have a prescription that comes in for a Ventolin brand inhaler, for example, but that Ventolin isn't covered by the insurance, a standard of care would probably reasonably say that a pharmacist could substitute with whichever albuterol is covered by the insurance, but a store's policy and procedure may prohibit them from actually doing it without reaching out to the doctor, resulting in a delay of the patient getting their medication. So that was just one that came up off the top of my head.
Thank you, Jesse. Great comments. Okay, so we'll go to public comment and let's see what we have. So, Trisha?
All right, I have opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or you may simply raise your hand. For people who've called in, you would just press *3. And I do see several hands raised, so we'll start with Christopher Adkins. You should be able to unmute yourself.
Hello. All right. So I believe I agree with most of the board members, specifically Maria and Renee here, when they were talking about how ultimately the decision-making process should be in the hands of the pharmacists. I don't have any problem with policies and procedures or protocols. I think they're necessary in a lot of the cases because, 90% of the time you go by a procedure, but there are the, 10% maybe of exceptions that don't abide specifically by that procedure or that policy, and you need to have the ability to deviate from that. So if it's treated more as like a guideline, like in general, this is what we want you to do, but ultimately the pharmacist has the ability to make the last call, I think that would be a much better scenario and something that I'm more comfortable with. And as far as, let me see. Yeah, so the last statement, could such practice impede a pharmacist's ability to exercise professional judgment? I think it absolutely could if we have scenarios where the business is able to create any kind of policy or any kind of procedure they want to dictate specifically what the pharmacist is supposed to do. Like Jesse had an example, I think I mentioned last time when I was at CVS, I tried to switch to a brand name, Synthroid, and the software blocked me because it was expensive. And it's written for brand and I can't do anything about it. So that's not allowing me to make the decision to switch it to the brand name medication. The software is stopping me there. The software is making the decision at that point, not me. So when we have things like that that we bump into with policies and procedures, the business should not be able to make that decision. But if we are switching to a standard of care model, then I think that is what should be that will essentially, in a way, be the policies and procedures, because we're going to build up a standard of care, which will kind of create a background framework of what what would another pharmacist do? What would their personal policy be? Not necessarily set in stone by each business, but by pharmacists at large making that decision. And we also do have guidelines already for a lot of the decisions that we make. So we, in a way, have professional policies and procedures that, again, aren't always right. You don't always go by the guidelines, but like I said, arbitrarily 90% of the time, they're right. And then you have to have that wiggle room for the exceptions, the hyper responders or the under metabolizers of certain things to make certain decisions. So I don't think policies and procedures inherently are bad. But when the business is using them to make decisions that are just cost savings and hurt the patients, that's where they become bad. So I think ultimately the question was, does the committee believe it's appropriate to allow the business to develop policies and procedures, or could such practice
10
impede the
seconds.
pharmacist's ability? And I think the answer exists somewhere in between. Policies and procedures aren't evil, they have their place. But at the point that they do impede that judgment, they become bad. Thank you.
All right, and our next speaker is Daniel Kudryshov. And Daniel, you should be able to unmute yourself.
Thank you. Daniel Kudryshov, speaking as myself as individual. Again, my background is hospital, health system pharmacy, and I may be differing in my interpretation of this question, but I think the answer depends on how we understand the standard of care enforcement model and how we define standard of care. The way I understand it, the enforcement model is not intended to govern clinical practice. The enforcement model is not intended to say what or to regulate businesses or impede employers' ability to create policies and procedures. That, in my opinion, that is not the intent of our standard of care enforcement model. So when we look at the National Association of Boards of Pharmacy, their definition of the standard of care, it reads, the degree of care a prudent and reasonable licensee or registrant with similar education, training, and experience will exercise under similar circumstances, right? So it's the degree of care one will exercise under similar circumstances. Now, the standard doesn't say that it's the degree of care one will exercise in compliance with the latest joint, let's say TJC guideline, I'm sorry, not Joint Commission, JNC guidelines for hypertension management, right? It doesn't specify a specific guideline. It doesn't specify what the circumstances are. It just says, how will a prudent pharmacist act under the given circumstances, right? So the circumstances are defined by the employer, are defined by the clinical situation, are defined by these expert panels that put forth clinical guidelines. The standard of care doesn't create the standard of care. It just says that how would a prudent pharmacist act in the given situation. So if the situation that we're concerned about, where employer has a rule that says that you cannot switch to a specific brand product, well, that is the standard that employer has set. So how would a prudent pharmacist act in those situations, right? So my response to that would be, okay, if the pharmacist in that situation, wanted to switch to the brand product because they had a very, very, very strong conviction that if they do not do so, they're going to harm this patient. Well, they have to escalate.
10 seconds.
Prudent pharmacist would escalate their concern with their employer. Otherwise, if they don't believe so, they can let it go. And so I'll stop there, but thank you for the comment.
All right, and the next request for comment is from Kevin Komodo. And Kevin, you should be able to unmute yourself.
I just wanted to speak with regards to both Dr. Atkins and then also with Maria's comments. I will tell you that when Maria was speaking about how they had applied protocols like in her practice setting, it was very, very exciting because I think that really actually creates a wonderful model for where it is that this could go and how the board could possibly conceive of like application of protocols or policies and procedures in these cases. And I don't want to speak too much because I think it was so eloquently stated by so many people. But the one thing that she said that really resonated was that, having protocols that focus on process and not clinical decisions, because ensuring that we do have some sort of a standard by which we can practice, but allows for that clinical decision making on the part of the pharmacist. If I were to break that down then into the parts that would like have to come into play from the standpoint of the implementation of standard of care, one of the things I brought up in a previous discussion was about empowering that pharmacist, the right to be giving them whatever type of legal backing they need to be able to make the thing that they feel is clinically appropriate given the case and the situation. And as Dr. Atkins had spoken about his patient that had possibly overdosed, being able to allow them that freedom. I don't know how we do that. This is something that's beyond my understanding about how the law would intersect it that way. But I think that mentality and that it seems to resonate with this board. And I'd just like to reiterate how important that is and how wonderful I think it is that you're going in this direction.
All right, and Richard Dane is next. Richard, you should be able to unmute yourself.
California Pharmacists Association. I'll be brief as well, but I do agree with all the comments that have been made by Dr. Komodo and Dr. Kujishov and also by Dr. Maria Serpa as well. Very much do believe that it would be a mistake to not allow policies and procedures. However, I do understand the discussion. I very much agree with Maria on how it's being utilized in the hospital where policies and procedures are in place for the processes and not for the clinical decision. And these policies and procedures that already exist in hospitals and ambulatory care clinics and some community pharmacies very much speak to that, where it dictates, the process of the steps that the pharmacists have to take to collect labs, conduct the interview, to document the information, but it does not restrict the pharmacist's ability to make independent clinical decisions. In our ambulatory care clinic setting in a community pharmacy, our policies and procedures outline the processes, and it does recommend which guidelines the pharmacist will use, but it provides for great flexibility. So for example, in our blood pressure hypertension management clinic, we might say that the pharmacist should utilize the most current version of the AHA hypertension guidelines, and that provides the flexibility for the pharmacist to provide the clinical justification for the decisions that they make for the patients. But the processes of how to conduct the interview, when to document, and all that information is outlined in our policies and procedures. So I do believe there is a role for it. And I again agree with what Maria has said about this topic. Thank you.
All right, and the next request for comment is from Rita Shane. Rita, you should be able to unmute.
Comments that came before me. I think some potential language to help support what some of my colleagues have said would be things like evidence-based guidelines, care that is consistent with current compendia. Things like that would enable organizations to then utilize the knowledge for the consistency that I think we all want to see in terms of how we provide practice. And at the end of the day, this is about providing the care for patients by the experts in medication management in a way that won't delay care, such that any things that occur currently, whether it's within the electronic information systems themselves or how practices are set up, would be unencumbered, so that if a physician writes an order that is clearly an error, there would be a way to manage that and not delay care to our patients based on evidence, based on current compendium. So we would not be operating without any structure. We would just want to ensure that how we operate is consistent with what we want for our patients. And I think that would take some of this kind of concern about going from our current model, which is very detailed for every type of drug therapy in the current law book, to enabling us to use current evidence and compendia and standards of practice that are actually published even within the pharmacy realm to guide the practice of pharmacy. Thank you for the opportunity to provide feedback.
All right, and that is the end of public comment. Shall I close the Q&A panel?
Yes, please. Thank you, Trisha. Thank you, everyone, for your comments. Really appreciate it. Members, any thoughts before we moving on to the next little question? So the little question A, for instance, is should patient care policies be required to be developed by the PIC or merely approved by the PIC? For me, I think that PIC should be involved in some sort of policies development. Members, your thoughts? I'll start with Jessie.
Thank you, Sung. I agree. I think in some capacity, the PIC should ultimately sign off on what patient care policies are going on in the store. To what extent, whether they should be in the developing process or approval process, I think is up for debate. I don't know if I feel strongly one way or the other, but I'm looking forward to hearing what everyone else thinks about this.
Thank you, Jessie. And Maria?
I think our care areas are so complex that we can't expect the PIC to be the expert in everything everywhere, but they need to be the responsible party. So they would hire or assure that they have subject matter experts in their employ or available that would help create those policies. So I would say merely approved.
Thank you, Maria. Renee?
I pretty much completely echo what Maria is saying. You know, I mean, of course, the PIC needs to, you know, have the awareness and know for the appropriateness of any kind of policies, but they may or may not be the ones who would appropriately be developing them. You know, again, they are managing all aspects of oversight of the pharmacy, so this may not be their complete wheelhouse, and hopefully they would know that. You know, and if it isn't, so it would really need to be, you know, some, you know, expert staff who could be writing these.
Thank you, Renee. And Indira?
All of that seems to make sense to me. It develop seems like a very involved process, and it seems like that might be burdensome, and as well as the PIC might be limited by their own expertise and their own knowledge. So I think some involvement somewhere, if it's approval, then that would be the right place for it.
Thank you. All right, Trisha, if you could go to public comment on that specific question, please.
Thank you. I'm opening up the Q&A panel. If any member of the public wishes to make a comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or you may simply raise your hand. And we do have a comment from Richard Dane. So Richard, you should be able to unmute yourself.
Hi, Richard Dane, California Pharmacists Association. I agree with all the comments. I do think that the PIC should have the final say and be involved in kind of the approval of the policies and procedures document. And just for some perspective, in the hospital and ambulatory care clinic practices where I'm at, we have committees that develop these policies and procedures, so that employees and pharmacists who are working in the clinics and working in the floors have a say, and that people who are experts in these topic areas have a say in how the documents are being developed. And so that committee develops the policies and procedures documents, and then ultimately gets approved by the director or the PIC. So I think a similar model could follow for any practice setting, including community pharmacy. Now, it might be a little bit difficult for a small independent pharmacy to have these regular committees where they may or may not have expertise, but I think some of the board members spoke about maybe getting consultants or other experts. I think from a corporate standpoint, it is possible that they could convene a committee involving multiple stores within that region that involves both PICs and the employee pharmacists to help develop those documents. But ultimately, the PIC for that specific location should be responsible for the final approval for utilizing it at that location.
All right, and I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you. Thank you for the comment, Dr. Dang. So next is moving on to subsection 7B. Could practice setting impact the power that the pharmacist has in setting appropriate patient care responses if scope of practice expanded by standard of care model? As I said, I am not a fan of having different settings. So that's my simple comment on that. And so we'll go to Maria. Your thoughts?
My turn to come up first again. I really don't like the idea of practice setting impacting that, the practice of pharmacy should have very similar, if not the same, activities at at all the different locations, including locations that we're not in yet. We will be in the future. I think that's going with the clinical decisions, where I think practice setting is when you're actually dealing with the products, and the product is all about the practice setting, but the clinical judgment is not.
Thank you, Maria. Renee?
Hi. Yeah, this is a very dense question. I guess I would say that yeah, come back. Let me really, I thought I had really a response, but I'm seeing it a little differently. Let me think.
Thank you, Renee. Indira, your thoughts? And I know you're an attorney, Indira, so you're always, I'm sure you're careful with your words.
I will say, I think there are some terms in here that just are still confusing to me. Again, attorney, but as a consumer. So in terms of practice setting, are we talking about that? I think being limited to certain things, or just generally practice setting generally, could it impact the power a pharmacist has? It seems like in the scenarios we've discussed, as to standard of care, that it could impact the power. Should it is probably something else to consider. And so again, just from the viewpoint of patient safety, seems like it could be a frightening scenario in the worst case scenario. And so I'm definitely curious to hear more about the opinions of what this means.
Thank you, Indira. Jesse?
Hi, I was also confused by this question, but I would say I ultimately landed the same as Indira, in that just based on what we've seen, even though in an ideal world we want the standard of care to be the same across all settings, I think it could differ if we were to expand scope of practice by converting into a standard of care model. Even just thinking of simple differences in policies and procedures that ultimately may lead to different care across different settings. This question is a lot.
Loaded question. Every question's loaded, it seems like. Renee?
Yeah, I think I'm just going to focus here on just for this practice setting impact on a pharmacist's patient care responses. And that would be a concern. I mean, again, I feel like this maybe harkens back to question 6, the way I'm reading it, in terms of, working conditions. So, there's that aspect, but yeah, so I'm just going to kind of go with I would be concerned that it would affect it negatively.
Thank you, Renee. Any other thoughts before we open up for public comment? We are ready for public comment, Tricia.
All right, I'm opening up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or you may simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I am not seeing any requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you.
You're welcome.
Okay, next question is question 8. We have already touched on this a bit, but in light of the survey responses, do we believe steps need to be taken to ensure pharmacists are empowered to provide appropriate patient care versus policies and procedure developed by corporations or businesses entities that dictate patient care? It's a tricky question from our previous discussion here, but I do believe in some ways there should be some steps to make sure pharmacists has autonomy, but Maria brought up great points. And so if we could have both, that would be ideal. So with that, I will start with Renee.
Yeah, so I mean, yes, I do think that pharmacists would need to be protected. I mean, ultimately, the patient protected. Anyway, from any kind of more corporate focused policies and procedures that don't include input from the pharmacists or originate from the pharmacists. Anything that might limit them from exercising clinical judgment for a patient. I think it seems much like a little segue from even question 7, but anyway, that's my thoughts.
Thank you, Indira.
I think the simple answer is yes. I think the motivations between corporation and business entities with respect to the motivation behind why they develop certain policies and procedures is very different than the motivation that pharmacists have to provide patient care. So I out of the two, I would definitely think that we want to empower the pharmacists more to respond to patient care and ensure patient safety. And I would not want that to be eclipsed by policies and procedures developed by corporations and business entities, which are not subject necessarily to the same oversight and regulations, and not necessarily motivated by the same purpose.
Thank you, Indira. Jesse?
Thank you. So truthfully, I read this question, and although based on the survey results and some of the feedback we're getting, policies and procedures can be a barrier to providing care. Honestly, my impression from the survey is more about working conditions being a barrier to appropriate care, patient care, rather than policies and procedures. And so it's difficult for me to say that pharmacists need to be empowered, because I don't think empowerment is necessarily the big barrier. I think the the biggest hurdle is really the working conditions and the burnout that pharmacies experience rather than the barriers of the policies and procedures themselves.
Thank you, Jesse. And Maria?
I kind of read this question a little bit differently. I think that to me, it seemed like it was pretty obvious that pharmacists need to be involved. And that's the word that I was using. Empowered, I don't know where that's taking me, or taking us. I don't think that we want to get involved with disagreements or arguments between employee and employer. If they, let's say they have some sort of process where pharmacist is adamant, I'm not going to do this or that, or I don't want to do it that way. And, 10 pharmacists says, yes, this is what we're doing. So the consensus is, there could be all sorts of things I could see go kind of sideways. I don't think the board needs to be involved with those kinds of things, and eventually they may end up terminating employment because of that person being difficult to work with. So there's a lot of HR things that are in here. So the word empowered kind of was, I would say, involved.
Got it. Thank you, Maria. That's a good point. So with that, I'm going to open up for public comment.
Thank you. I'm opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. I do see we have Christopher Atkins with a comment. So Christopher, you should be able to unmute yourself.
I want to say, Maria, I agree with you. The word empowered is kind of giving me pause here because I'm not sure exactly what is meant by empowered, or if that's something that the board or legislature necessarily needs to have involvement with. But the more I think about it, sorry, I do believe that the pharmacists, especially in the community setting, do need to be more empowered to advocate for their patients, I guess is what I would say. They need a little bit more empowerment, a little bit more support, that they're the ones making the decisions, not necessarily the business. Do I think that's something that needs to be legislated or decided by the Board of Pharmacy? No, not necessarily, because you do get into issues with maybe the person is just difficult to work with. You could get into some employment issues there. But is that something maybe that needs to be addressed by CPHA or a pharmacy organization to empower the pharmacists more and address it on that end? I think that might be the answer there. But yeah, the word empowerment is definitely giving me pause there. Now, I wouldn't want to give all the power to policies and procedures, obviously. But yeah, I might want to change the word empowered, but I do think it needs to be addressed in another setting, maybe at an organizational standpoint, like from CPHA or APHA. And the kind of how, like what Jesse was saying, burnout is also an issue there. So I don't think it's necessarily just empowerment that needs to be taken into consideration. So maybe this actually is a question that might need to be addressed by CPHA or an organization like that to address burnout and empowerment of the pharmacy. Thank you.
All right, I see no further requests for comment. Oh, I'm so sorry. We do have Rita Shane. Rita, you should be able to unmute yourself.
Thanks. Just along the lines of the previous input, it almost doesn't seem like this belongs here. This is, to me, a pharmacist acting in the interest of the patient and a conflict with business interests or policies of an organization. It's not even a standard of care issue. It's almost like a chain of command issue where someone feels like they can't do the best for their patients and it needs to be escalated. So I read it about 5 times, several times this week, trying to understand it. And the more I look at it, the more I think everything we've discussed so far is creating kind of a structure and a process to support our ability to take care of patients based on evidence, based on best practices, based on guidelines, using committees or structures to ensure consistency. So that's what we want to do. Anything that disrupts that pharmacist-patient relationship to provide safe care is an issue that needs to be addressed at at the employer level, frankly. And professional committees can provide guidance as to what best practices are. But at the end of the day, every pharmacist has a responsibility to escalate when they feel that a policy interferes with their ability to do the right thing for their patients. So I kind of like it. It in a way doesn't seem to fit in my head, at least within the standard of care discussions we've been having. Thank you.
All right, I see no further requests for comment. Shall I close the Q&A panel?
Thank you. Thank you for the comments. Okay, so the next subsection question is how does the board ensure that patient care policies are being developed by licensed pharmacists? Is that really something that we need to contemplate? I I don't have an answer for this one, so I'm going to punt this to India. What do you think?
Is the question, if we moved to a standard of care model, how would the board ensure that patient care policies are being developed by licensed pharmacists? Is that the
That's correct.
question? Okay,
That's the
so that's the
question.
assumption. I don't know, because it would remove I don't know where it would give the board any authority or ability to do that. If we move to a standard of care model, I don't, than through legislation, I'm not sure how that
Thank
would
you.
work.
No worries, India. This is not an easy question to answer. Yeah. Jesse, what do you think?
Hey, so I already kind of answered this earlier, but I feel very strongly that it should not just be licensed pharmacists and licensed pharmacists within California, but pharmacists who are actively practicing within that setting, who are creating the standard of care. Just as an example, in many chain retail pharmacies, you may have a district leader who is either not a pharmacist or pharmacy technician at all, so someone who may have no experience in pharmacy who is supervising pharmacists, or you can have someone who's a pharmacist in a different state. So it's really important. I've had that personally in the past. So it's important to me that we have actual working California pharmacists developing these standards. How that would actually happen is a big question mark. I'm not sure if there's certain outreach or recruitment we can do from the board, but maybe that's something that Anne can provide us more information on. Just to ensure that we're actually getting the appropriate pharmacist kind of creating the standard, or if it's something that wouldn't happen until, I guess, an issue came up with the board or a complaint. From what I remember from the Idaho hearing about the Idaho State Board of Pharmacy, it sounds like a lot of things are only addressed when there's actually a complaint. So in that scenario, is the recruitment process only done after there's a complaint that already exists? I'm not really sure.
Thank you, Jesse. Maria, what do you think?
This one I think I'm a little bit more clear on. That's why I'm kind of interested in hearing everyone's opinion, because it hasn't really changed too much. I think it needs to be approved by the PIC, but I don't think it needs to be developed by pharmacists, because you could have physicians creating like hypertension guidelines. And I don't think it needs to be California licensed healthcare practitioners, because I may try and find something that's better at, a tertiary care facility or academic setting that's on the East Coast, that I may use their policies or their guidelines. But I think it's the PIC's responsibility to review them and approve them. Who develops them could be a lot of people, and they may not be pharmacists. It could be physicians.
Thank you, Maria. Renee, your thoughts?
Yeah, I think that the how it would be ensured, I mean, obviously comes to mind regulatory, but I don't know that that's really even appropriate. But hopefully, in these settings, like in community or something, like the corporations should be motivated to, provide, want to have those provided by the pharmacists who are actually the the knowledge owners and also providing the standard of care practice. But yeah, somewhere then it circles back though, because if they're following under something like Maria mentioned, I mean, it have to be reviewed by the PIC. But I also agree with Maria in that different standards are developed in various places that are being followed. But ultimately, there would have to be some kind of consistent, I mean, in my opinion, it's some kind of consistent practice that they're following the best practice guidelines wherever that is coming from, whether it's a like national organization. I mean, they're not necessarily state specific, but they would have to be adopted in at least in that one practice setting. So it would have to be developed by pharmacists. I don't know how that could be enforced, again, except for, the regulatory requirement, which hopefully there could be some other way. That's my thoughts.
Thank you, Renee. Okay, so with that, we're going to open up for public comment on that question. Question 8A.
Thank you. I've opened up the Q&A panel. If any member of the public would like to make a comment, please type comment using the field in the lower right-hand corner of your screen and send it to all panelists, or simply raise your hand. And I do see that Richard Dane has a comment. So Richard, you should be able to unmute yourself.
Hi, thank you, Richard Dane, California Pharmacists Association. I'm a little bit confused about the intent of the question. Is the question asking about patient care policies specific to the institution, or is it referring to the patient care policies that would create the standard of care that the board would enforce towards? Because my answer would depend on that interpretation. If it's the former, where it's the patient care policies of the institution and pharmacy or facility, then I would agree with Maria's comments. Thank you.
All right, the next request is from Daniel Robinson. And Daniel, you should be able to unmute yourself.
Thank you. I honestly don't think the board should be involved in developing or ensuring that those policies were developed. That would be part of the discovery process. So it was mentioned in Idaho, it only comes up if there's a complaint. So if there was a standard of a quality of care complaint lodged against the pharmacist, part of the discovery process would be what policies or procedures were in place. Did you follow those policies and procedures? And then possibly, an expert witness might, comment on the validity and that, that does make sense and it's current. But this is part of the enforcement part, not part of the developing a standard of care model. You wouldn't, because it's impossible. I mean, healthcare is so complex and pharmacists are doing so many wonderful things in so many different areas. For the board to be involved in enforcement of the development of policies, I think you're taking on too much, honestly. Thank you.
All right, and next we have Christopher Atkins. Christopher, you should be able to unmute yourself.
Yes, I think I'm going to agree with the previous commenter here. I don't really think the board should be concerned with the minutia of enforcing how the policies are developed, because I'm just thinking about how you would trace that back, and that just seems incredibly cumbersome, because it's not like every single person that's involved in development is going to sign their name to a piece of paper or something. And I mean, even if they do, it's just a name on a piece of paper, so you can just put anyone's name down, really. So I think that that's something that would just, I think it would just, honestly, I want to say it would be a waste of time. But at the same time, I do want to go back to Jesse's point, saying that licensed pharmacists should definitely be involved. It shouldn't be decisions that are just being made by a business or anything like that. But the question here is about how the board should ensure that. So if I'm answering that question specifically, I don't think the board should be concerned with that until a complaint arises, maybe. So I think that's going to be my answer there. Thank you.
All right, I don't see any other requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Trisha. All right, the next question. So next question is, if the committee believes that moving scope of practice to a standard of care model is appropriate for all settings, does it believe, similar to the Medical Practice Act, that there should be a bar on the corporate practice of pharmacy? Obviously, this is a tricky question as well. I think the bar on corporate practice of pharmacy removes the competing profit interest that exists in some settings, but I'm honestly not sure how we would achieve this or even possible in current arrangements. Members, your thoughts? Jesse, starting with you.
Thank you, Sung. So I would say yes in an ideal world, but just kind of echoing what you're saying, this to me just isn't realistic to happen. I don't see how that would be possible because we would be eliminating potentially eliminating so many thousands of pharmacies that exist throughout California. So I don't see how it would be feasible, even though I think it should be.
Thank you, Jesse. Maria?
I agree. I apologize. I was off mute for a while there. She might have gotten some background. I agree. I think it's impossible to do. So I don't have anything else to add.
Thank you, Maria. Renee?
Yeah, I mean, while I, certainly understand the motivation behind having, something like this, I think the reality or practicality does not seem possible. That's what I'll say.
Thank you, Renee. And Indira?
I guess, should there be, I guess, are we saying that it would be impossible to do? I guess I'm confused.
I apologize. I think the questions were developed sometimes to answer the obvious maybe, but also just to give a broader perspective on the holistic perspective of a lot of things. So I think, should we? Can we? So that's kind of the question. Do you believe the committee do you believe should the bar on the corporate practice of pharmacy, should there be a bar or can there be a bar? So that's kind of where we are.
I think if the committee does believe that there should be a movement towards a standard of care model, then I do believe the committee should consider the possibility of a bar on the corporate practice of pharmacy.
Thank you, Indira.
Hey, Sung,
with that-
I have one thing
Yeah,
to
go
add,
ahead.
sorry. It also just kind of like thinking about this question and just the corporate ownership of pharmacy, it also makes me reflect on pharmacy benefits managers as well. And I think that's something that we should take into consideration as well. If there were to be a bar or vice versa, what all of this would mean to not only the corporate ownership of the pharmacy, but also of the pharmacy benefit manager as well, which may not necessarily be our scope, but I think it's relevant to this discussion.
Thank you. Great point, Jesse. Okay. With that, we will open up for public comment. Trisha, please open the line for public comments.
Thank you, Mr. Board President. I am opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. We're displaying instructions and we'll give you a moment. All right, we have a request for comment from Christopher Atkins. And Christopher, you should be able to unmute yourself.
I think I don't really understand the question. When they say, should there be a bar on the corporate practice of pharmacy, does that mean bar as in prevent pharmacies from being corporately owned? Is that what that means? Or a minimum bar? I'm having trouble with the word.
And do you want to jump in on this? I'm sorry, not trying to force you to have a conversation, but if you could just explain, or Eileen, whoever, the practice of medicine and versus pharmacy.
I think it's probably better coming from an attorney, but yeah, I think it's essentially prohibiting a corporation from driving the clinical practice. I think that I'm oversimplifying that, so I'm going to stop talking to an attorney who can actually say it correctly.
Okay, yeah, well, yeah, if that's the case, if it's just barring pharmacies from being corporately owned, I don't think we should do that. I don't want to do anything to interfere with the business or development of pharmacies or anything like that. I mean, I personally would like to see most pharmacy and medical practice in general be kind of handled on a smaller scale, just because when you get into larger corporate situations, speaking from someone that's been practicing in like a corporate chain setting for a long time, sometimes a lot of your decision making power is taken out of your hands, as I've said several times. So that's my only concern with the corporate side of it. I don't think it should be barred entirely, but I do think it's something that needs to be taken into consideration. Definitely, I mean, we saw in the survey that there's definitely a difference in the corporate side of pharmacy and the as opposed to like hospital or ambulatory care, where it is at the moment less corporate. Thank you.
All right, I don't see further requests for, oh, I spoke too soon. Kevin Komodo, you should be able to unmute yourself.
Thank you very much. I will also voice my complete confusion as to like the how this would work in the application. But as I'm kind of gaining a little bit of knowledge about it, one of my concerns would be in the independent space, so my practice setting. Even for independent pharmacies, there are some of us that do operate very small, like operations in which we do have a corporation involved. We're definitely not talking at the same level as like some of the larger institutions. But my only concern would be if there would be anything that would affect that like that independent sector, because some of us are constructed as corporations. So I just want to make sure that as we're going, if there's certain things that are that we're trying to target larger corporate interests and the mandating of a certain type of practices, that we don't base that off of like how it's incorporated. But you know, I think getting back to the nature of what Ms. Sodergren had stated as far as the you know, ensuring that there isn't an interest that is impeding clinicians' ability to make clinical decisions.
All right, and next we have Richard Dane. Richard, you should be able to unmute.
Yeah, I just want to echo all the comments before. And I think if what we're really trying to get at is not necessarily banning the corporate ownership of pharmacies, but preventing or limiting the corporate authority to make decisions at a patient care level that the individual PIC or individual pharmacist should have the authority to do instead. So even if someone is working in a corporate owned pharmacy, those decisions should not be dictated by the corporate owners, but rather by the individual PIC or pharmacist.
All right, I see no further comments. Shall I close the Q&A panel?
Yes, please, Maria, go ahead.
I just wanted to add one thing. I think because I also, when I think of corporate, I think of retail or ambulatory. Corporations are involved at all levels of healthcare. You know, we have lots of home infusions, we have compounding pharmacies, acute care hospitals. I think the word corporate would has an interesting legal definition. And if we discuss this more, I think we probably need to have at least a few attorneys around.
Thank you, Maria. Okay, it's 4 o'clock. Just serving members if anyone needs a break.
Yeah, could we do like 5 minutes maybe?
Okay,
5
let's
minutes?
do 10 minutes. We'll do 4:10, 4:10. Okay, we have a quorum. So for the interest of time, we're gonna get started on question 9. Again, thank you everyone for enduring through all these questions. The questions are meant to, you know, create dialogue and also just to contemplate on issues wide ranging related to standard of care. So thank you for enduring through all the questions and providing your thoughts and comments. So question 9 is, what aspects of pharmacist clinical practice, if any, does the committee believe should not transition to an expanded standard of care enforcement model? Tricia, could you go to that slide? Whoever's in charge of the slide. Thank you. There it is. I'll start by saying that I believe that the board transitioned to an expanded standard of care enforcement model. It is imperative that we convey to licensees a clear understanding that federal laws and relevant state laws are still applicable and would form the basis for license discipline or administrative action. With that, we'll start with back to Maria, I believe.
Oh, thank you for asking me to go first, since the example there is something that's near and dear. I think there are some areas, and I'm not sure of all of them, but specifically with compounding, where we have higher standards in our state than many other states and higher than the federal standards. And so we don't want to lose that and go back at some point. And we do have those discussions currently with members of our pharmacy community that would prefer the lower federal standard than the higher California standard. But in the interest of patient safety, our standards are higher in some areas. That's all.
Thank you, Maria. Renee?
Yeah, I think it's kind of been mentioned previously and a little bit by both of you, which is, you know, I mean, well, it seems obvious, but to me personally, the operational aspect of pharmacy has so many specific requirements for, you know, drug storage, compounding, drug management, which, you know, are have a lot of very particular prescribed requirements as necessary for medication quality, those are best regulated with exact language. And, you know, as Maria pointed out, there's, you know, in particular, California having, you know, other, like the standards are not exactly equivalent, they're higher, where it seemed like there was gaps. So wouldn't be appropriate in that setting, in terms of that type of very scripted management of drugs or operations of pharmacy.
Thank you, Renee. Indira, back to you. I see you're here. And so just question 9, what aspects of pharmacist practice, if any, does a committee believe should not transition to an expanded standard of care enforcement model, if any?
That, you know what, that is, I think, a hard question for me to answer still. And I think all of our questions leading up to this really inform this. So I think there's still, in my mind, there's still a lot that I have to learn to be able to answer. I think there's so many, it's, again, just a very loaded question.
Understand, yep. And Jesse, your thoughts?
I completely agree with what was said before, especially in regards to compounding. We don't want to compromise the standard of care that may be higher than the federal standard. And I guess I'm going to pose a question, and I apologize if we've discussed this in the past, but from what I remember from previous discussions, some of the supporters of standard of care transition mentioned that the regulatory burden does decrease. So I guess my question posed to the board is, if we were to transition to a standard of care, is the expectation that our regulations get consolidated, or is it expected that the regulations that exist will remain in place in addition to the federal, and then just the enforcement model is a standard of care? Because it seems like when Idaho transitioned, if I remember correctly, their regulations actually were consolidated. So I guess that's a question. I don't know who is the right person to really pose that to, but that's kind of something that I think about.
Great question, Jesse, and something that we probably have to address at future meeting and part of our report potentially. Okay, so with that, we will open up for public comment.
Thank you. I am opening up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or you may simply raise your hand. And I see that Christopher Atkins has a comment. So Christopher, you should be able to unmute.
Yeah, the only thing that would concern me about this is potentially creating like a tiered system with pharmacists. Like some pharmacists are treated one way and some pharmacists are treated another way. And I think that could kind of get into a little bit of confusion for pharmacists, especially since we're pretty much able to transition to almost any type of career within pharmacy. Like there's no reason that I couldn't go be a compounding pharmacist or an acute care pharmacist or an ambulatory care pharmacist. So I'm kind of thinking about just if the pharmacists are treated differently, what is that going to mean for us? Is that going to create some kind of, I don't know, potentially even like animosity between pharmacists? Like I'm this type of pharmacist and you're that type of pharmacist. We're two completely different people. And honestly, at this point in the state of pharmacy, I don't want to do anything to divide us whatsoever. We need to come together more. So that would be a huge concern for me here. And I might be reading into it too far, honestly, and I might be too in the trenches at this point also. So kind of take that into consideration with my comment. But that's the one thing that concerns me here is creating a class system of pharmacists with this. Thank you.
All right, I don't see any further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Tricia.
Welcome.
Great comment, great thoughts. That's something that we should probably have included in the report. So next question is basically.
Song, can I just say something real quick?
Oh yeah,
Just
go
kind
ahead,
of in
Renee.
response. I think just as I'm seeing it, and from my own experience, which is in health system pharmacy, there's this spectrum of pharmacist functions, and so it's not necessarily creating two different classes per se. I mean, I'm just kind of as a response to this, but so it's not really mutually exclusive here. It's just that like all of these whatever activities need to get done, right? I mean, having, there's a lot of knowledge base required in operations. So, and, especially as you have a larger pharmacy or pharmacies, right? I mean, drug storage, automated dispensing cabinets, a lot of technology, sterile compounding, IV workflow systems. So, there's operational specialists, if you will, as well as clinical. So there's just, I mean, pharmacists are amazing, right? I mean, just all the things they know. So I feel that this would be more of a requirement based on the functions, and also that like in certain settings, like in a hospital, I mean, you will have staff who have more clinical functions still also provide operational staff operational shifts. And so they also are required to know some of that. And sometimes those things don't go both ways, but they often do. So anyway, just wanted to say that about that.
Thank you, Renee. Any other member comments? Okay, the next question. So for example, does the committee believe that a potential expansion of scope of practice should be limited by setting or limited to clinical practice, i.e. pharmacists providing direct patient care outside of their traditional dispensing role? I resoundingly say no, but that's just my opinion. And we'll start with you, Renee. Sorry, this just happened to work out to be that picking you for the first.
That's fine. Yeah, I would agree. No, I mean, I don't think limiting it, um, it really serves the public. I think it can be expanded to both.
Thank you, Renee. And India? Indira's video's off, but I think
Sorry, here we go. Sorry, my bad. I thought, anyway, apologies. Uh, I don't think there would be a way to limit it that would make any sense. Simply put.
Thank you, Indira. And Jesse?
Hi, so I don't think we should necessarily limit it by practice setting, but I think there are some factors that we need to keep in mind. You know, just based on workforce survey of independent pharmacies versus chain pharmacy settings, also just layout of the pharmacy. You know, I think we can all probably agree that a more clinical setting or a private room would be more appropriate for things like PEP and PrEP furnishing. And so just taking those other things into consideration, but I don't think universally, you know, we should be nitpicking which areas we expand the scope of practice to for reasons like the public commenter had previously said, where you know, we're fortunate to be in the sort of industry in which we can transition from one practice setting to another. And so for that reason, it doesn't necessarily make sense to limit the expansion of scope of practice to one setting.
Thank you, Jesse. And Maria?
Clean sweep, I agree. My answer would be no.
Thank you, Maria. All right, with that, we'll open up for public comments. Trisha?
Thank you. I'll open up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. We are displaying instructions and we'll give you a moment. All right, we have Christopher Atkins with a comment. Christopher, you should be able to unmute.
I would just say no would be the easy answer. The only exception I could think of might be the advanced practice pharmacist, because they do have a little bit more authority than a regular pharmacist has. But the answer would still be no in that case, because I don't want to limit them either. I don't want to limit anyone. I think the word we're all saying no to is the limit part. We don't want to limit anyone. So yes, no. Thank you.
All right, and I don't see any further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, Trisha.
Okay.
Okay, this has just been a long journey here for our questions, and I think we probably have a few more questions coming up in the next couple meetings, but this is the last question for the day. The last question provided for our consideration is if we believe, as part of our report to the legislature, we should include a recommendation that expansion, and apologies, expansion may not be the right word here, but expansion of scope of practice for pharmacists is appropriate. And if so, how and in what areas? This is a big question, obviously. I believe it is appropriate to offer recommendations, though, especially given that a lot of the information we have received through this process focused on what some consider expanding scope of practice solely in the clinical setting. A few areas that I think may be appropriate would be including test and treat for things like ear infections and strep throat, also prescribing for pink eye, etc. I believe we should also have authority similar to that of Idaho to allow for pharmacists to autonomously adopt an existing prescription written by another prescriber if the action will optimize care and reduce burdens. This should also include completing missing information on a prescription, as is allowed in Washington. I believe we have received comments during our meetings about challenges experienced by pharmacists attempting to reach prescribers when a change is necessary, whether it's in a community pharmacy or a hospital. And when such challenges occur, patient care can be negatively impacted. So I think providing treatments for disease like that can be confirmed with CLIA wave testing is home run and no-brainer. Also providing maybe treatments for self-diagnosable conditions, as well as obviously self-diagnosable is debatable. But so just bringing real world experience, pharmacists working in a retail setting, and whether we like it or not, the vast majority of pharmacists are working in a chain community setting. So being able to have a deep enough conversation though with a patient like at a doctor's office is not a possibility. So do we also need to ensure that these are great ideas and we're moving in the right direction, but you know, we also need to think about unintended consequences and intended consequences. So do we need to say that their, you know, functions are performed only if there is another pharmacist available, another area with greater privacy? So, sorry again, loaded question of the question, but it's a complex issue, obviously, and that's why we're all here to try to debate and decide and contemplate. So, with that, we'll start with you, Indira. Sorry that it just falls on you for the first. We'll skip you. We'll go with Maria. How about that? Let's do with Maria. We'll start with, and then go.
I get to be the first one. This is the question I think we're going to be talking about for quite a while. Because myself, I do believe that we have an opportunity to embrace a hybrid standard and care enforcement model. I'm trying to use the terms correctly. And the emphasis is on hybrid. And that's, I think that's where the difficulty is. If it was all of one or all of the other, then we don't have a lot to discuss. But because of a hybrid, it's what do we include and what do we exclude? What do we make a hybrid and what do we actually make fully standard of care? Those are, I think, the devil's in the details. And that's where we want to make sure that we get exactly what we want for standardization, patient safety, and advocating for patients without those unintended consequences that often occur when a good idea can go left. So I am cautiously optimistic and look forward to further discussions. And I'm sad to say it doesn't sound like it's something that's going to be quick and easy, but I look forward to the discussions.
Thank you, Maria. Thank you. That's great points. Will be long process. Renee?
Yeah, so I also believe that it's appropriate for pharmacists to be able to expand their scope of practice, work at the top of their license, you know, what it's called, and provide patient care services using a standard of care model. Community practice settings, which have they provide patients with local access to healthcare, would benefit greatly from expanded role of pharmacists and more clinical services, including management of, you know, chronic diseases, which has been mentioned, diabetes, hypertension, test and treat. So, but yeah, again, the road to that is why we're all here.
Thank you, Renee. Indira?
You know, based on everything that has been presented, there are clear examples where expansion of the scope of practice can help patients and lead to greater equity in care and all sorts of great benefits. But I think one of the things we haven't heard as much about or hasn't talked about the sort of the worst case scenarios when we're talking about patient safety. And I think that's still, for me, a question that we need a lot. But I mean, we'd have to think about it. And if there was a report to the legislature that is recommending expansion of the scope of practice, I guess the if so, how and in what areas, I would like to see a great deal of discussion related to patient safety.
Indira and Jesse?
Thank you. Sung, I agree with a lot of the specific elements you pointed out. Like there is an opportunity for, you know, strep testing in a pharmacy, UTI testing. I would even go so far as to say epinephrine prescribing or furnishing rather. and possibly even expanding naloxone furnishing as well, especially given programs that are trying to make it more accessible for people to have on hand just in case. The biggest thing for me is I can't just overall say universally yes, because I think there should be specific conditions met. Like you had mentioned before, a private area for clinical service is absolutely necessary. You know, we shouldn't be doing any sort of testing in the middle of like a produce aisle, for example, or out in front of everyone where you don't really have a private area. Also, just making sure that the staffing is appropriate. I would say that there should be a second pharmacist who's outside of workflow in order to perform tasks like that. Now, I'm thinking from the chain pharmacy setting, perhaps, and I would love to hear feedback from independent pharmacists. Maybe in an independent pharmacy, a second pharmacist may not be necessary depending on the volume, but that's something that I'm open to hearing. The one thing that I just want to keep in mind is how do we already know that our pharmacists are burnt out in California. We know that that increases the risk for medical errors. So how do we ensure that we're expanding the scope of practice without increasing the burden that our pharmacists are already experiencing? So I think setting like this baseline kind of standard of what needs to be in place in order for these expanded roles, I think are appropriate. Also, just making sure that our regulations are keeping up to changing guidelines and making sure that we don't have to continuously update them and we're not behind. Overall, I think Maria just hit the nail on the head saying that, you know, the big question is figuring out this balance of a hybrid model and which elements need to be fully one or the other. And yeah, that's where I'm at for everything.
Thank you, Jesse. And since this is the last question, I mean, we don't have to cut short or anything, but I'm just gonna say one more thing, which is, you know, I want to look to the future, you know, where more pharmacists are able to provide clinical services, whatever that may be, to patients and not so much focused on dispensing. You know, understanding we have been trying to do this for the last many, many decades, but I think we are progressing. We've really been able to demonstrate it during the pandemic, how pharmacists can do so much more than just dispensing in terms of so much part of people's lives. We are truly a healthcare provider, and we should look to the future in solving healthcare together. And so, you know, with that, I just want to be mindful of that, hoping that we could, you know, look to the future in resolving all these issues to make Californians healthier. I'm just gonna open up one more time before we go to public comment. Anyone want to say anything? You've all said your work. You've said your pieces. All right. So we'll go to public comment, and we're almost there.
Okay, I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. And I see a request from Daniel Robinson. So Daniel, you should be able to unmute yourself.
Thank you. And President O, I really appreciate your final comments about the future of pharmacy and the opportunities that are out there for us. I really think that the problem with the way we see scope of practice and the way we implement it, it becomes a legal scope of practice. So it gets written into the law, it creates regulations, and that's going to be a very slow process. Whatever we do is very slow. It's always adversarial. As you know, the California Medical Association, American Medical Association, they take great pains to make sure that anybody who is trying to expand scope of practice, they're pretty much opposed to it, and they put big dollars behind that. And so it's very costly for us to also change scope of practice. So I would, and if you look at the Medical Practice Act, the word scope of practice or the phrase doesn't exist even one time. So within medical practice, the law doesn't specify what their scope is. because it all falls under a standard of care model. And that's what I think the beauty of moving towards standard of care does. It takes away from this legal scope of practice that is very slow. So when the new COVID vaccine was available, we had authorization to give vaccines, but only for those that were approved by the FDA. We had to go back and change the law to say approved or authorized by the FDA because that was under emergency use authorization. That was a legal process rather than, whoa, there's no other health profession in the world that would be delayed in that way from just taking care of patients, right? So we've got to be very careful. And if you think about SB 493 and all of the scope of practice issues that were made possible, it was all self-diagnosed conditions. It was, PEP and PrEP. It was self-administered hormonal contraception. It was travel medicine, preventative and prophylactic therapy. So I think if we can find broad language to say, this is what pharmacy is, this is how pharmacy can serve the public. We're not competing against physicians if we're not diagnosing congestive heart failure and starting to treat it. So we're not in the realm of doing that initial diagnosis, but certainly we're in the realm of providing much greater access to care for our patients. Thank you.
All right, and next we have Christopher Adkins. Christopher, you should be able to unmute.
Well said, Daniel. That was probably exactly what I was going to say, only said much more eloquently. So I agree with that wholeheartedly. And I think, as Dr. O said, and we've said previously, pharmacy practice is going to change in the near future, or in the future. And it's probably long overdue for that change, honestly. I mean, we have the knowledge to be doing a lot more than we're doing right now. And that might be one thing that's holding us back as a profession, is just not being able to practice at the top of our license. I'll be a little bit morbid here and say that pharmacy school applications have been declining since about 2012. And they took a big hit this past year. I know the school I graduated from, they are having a really hard time filling chairs, and I know several other schools are too. So it's a good possibility that over the next couple of years, we'll be seeing a decreased amount of pharmacists in practice. I know a lot of people have been leaving too, retiring early, moving into other industries or being entrepreneurial and doing other things related to healthcare, which is great. But we do need pharmacists. We need frontline pharmacists. We need hospital pharmacists. And I think a great way to do that, I mean, if nothing else, as a recruitment tool, is just expanding what we're able to do and using those years of education and those years of torture in pharmacy school that we went through to learn everything and to help patients, and just being able to actually use that and taking the handcuffs off of us and allowing us to practice. And we're not trying to take business away from doctors. We're not diagnosing anyone. We're just doing what we were trained to do. And that's, provide the best medication care that we can, because that's what we're the expert in. So I think that it's absolutely appropriate to expand the scope of practice. Now, I will say that we are losing pharmacists, and there are working condition problems. There are burnout problems. And that is something that absolutely needs to be addressed, probably hand in hand with this, if not separately. But I would be remiss to just say yes without putting the asterisk of the working conditions that we're under currently next to that. And I wouldn't say that's in any specific area. I mean, obviously the working conditions, well, I wouldn't say obviously, but I think they are a little bit worse in the community pharmacy. I know it's happening in the hospital as well. But like I said earlier, I don't want to differentiate between any areas of pharmacy. I don't want to limit anyone. I want all of us to be able to practice at the top of our license. And like I said, have those handcuffs taken off and kind of have a revitalization of the career of pharmacy. Thank you.
All right, and next we have Kevin Komodo.
With regards to the comments that were made before me, also in 100% agreement, I believe Dean Robinson made a wonderful statement about the difference between scope of practice and standard of care. Going back to question 10, I think it was, asking about, does the committee feel like they're on board, with expanding the scope of practice. And I think that the sentiment resonates with this group that there is application for a standard of care model to do that. I think that the second question, if so, how and in what areas, it starts becoming a self-defeating question, because now we're moving back away from what we talked about, trying to increase the availability of pharmacist services from a patient safety perspective, and going back to that. Okay, now how do we define each of those pieces, and how do we dictate how those things are going to occur? Because I feel that that's a dangerous question to ask, because there is a patient safety side in which we need to create regulations for safety, but there's also a safety piece that we're missing by not allowing access to services at the point where they're needed. And President O brought up great examples of how that's playing out and where those gaps in care are occurring. We had one that occurred today, in which we have a advanced practice pharmacist that's working in a clinic setting, and we have a patient that is uncontrolled in their diabetes management. In the advanced practice pharmacy, as people were putting it together, the regulation, and trying to think about all those situations that the patient would need, or what the pharmacist would need to care for the patient, they allowed for the initiation of drug therapy. But in this particular case, we're not able to initiate the glucometer that the patient needed, the test strips, and the other monitoring devices that were required. It's just one example of how we can't contemplate of all these examples of every single thing that we would need in a particular situation to appropriately provide care for that patient. But if we move more towards the standard of care model, I think it's going to expand those abilities for the pharmacist to be able to step in and to be able to provide some of these gaps, to address some of these gaps that these patients are facing. Thank you.
And next we have Richard Dane. And Richard, you should be able to unmute.
Hi. So yeah, regarding the policy question, I agree with a lot of what has been said already. I think I just want to add one more thing that Dr. Komodo said. The discussion around patient safety isn't necessarily around what types of services or conditions should be allowed or what areas should be allowed. Patient safety lies in the process of how the pharmacist delivers the various services. My next comment is around whether standard of care should be limited to certain disease states or certain conditions. And I think that's contrary to this whole concept of standard of care. The healthcare is a wide field, and there are pharmacists who practice in many different areas, even areas that we may not be necessarily aware of, or that may be up and coming. There's pharmacists in oncology and infectious disease and hepatology and pulmonology and cardiology, et cetera. And to define the specific diseases or conditions or medications that can be allowed through standard of care is contrary to the entire concept of what we're discussing. So it definitely discouraged the committee from moving in that direction. I think the better direction to move in is a little bit of what Dr. O had kind of mentioned, is allowing pharmacists to be able to be involved in the medication management and furnishing and administration of medications when there is a diagnosed condition, or when there's a self-treatable condition, or when there's a condition not requiring a diagnosis, or in a scenario where there is a readily available CLIA waive test, like for HIV and Hep C and STDs and UTIs, et cetera. So I think in those settings, you can set the parameters of how standard of care can be effectively utilized without specifying the specific disease states and the specific medications that might be involved, by setting the parameters of which it would be allowed to use in all of those different settings that I mentioned, with a diagnosis, conditions that don't require to be diagnosed, that are self-treatable, or that can be easily identified with the CLIA waive test, for example. So I think that would be the better route, as opposed to limiting which specific areas or conditions you might consider standard of care to be utilized in. Thank you.
All right, I don't see further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you, everyone, for great comments, thoughts, questions, all of the above. It's been long 2 days of meeting, and it's been very, very insightful, so inspiring for all of you and all the participants And so we are ready to adjourn. Before I go, though, I just want to make sure there's committee members have nothing else to add. Okay, everyone's all tired. It's getting dark now already. It's 5 o'clock. So before we adjourn, I'd like to thank everyone for your participation today. It is my hope that over the past several meetings, we have all learned from each other, including seeing other perspectives on this topic. It is my hope that prior to our next meeting, staff will begin preparing the report and that a draft will be available for our review. Also, if there's any other additional questions that anyone would like for us to ponder on, contemplate, please email or submit however you'd like to us. And so we will definitely consider those as well. February 1st is our next meeting. And so therefore, the meeting is adjourned. Thank you, everyone. And we'll see you in December for our regular meeting. Bye, guys.
Thank you.